say good morning, and then everybody looks at you. Oh, come on. So, good job. My name is Jason Hanford. I am an attorney at the Chartwell Law Offices. I specialize primarily in workers' compensation law in Pennsylvania, defending insurance carriers and employers throughout the Commonwealth. I sometimes delve into other matters, a little bit of employment law, and a little bit of somewhat niche stuff like medical marijuana, which is becoming a pretty big niche. I want to thank everybody for coming here today. We enjoy doing these things. It's good to get out and have discussions with our clients, with people who aren't our clients, with doctors and professionals in the industry. It's a good way to educate ourselves, and frankly, it's a good way to do something different. You know, you don't have to sit in your office today and do what you did yesterday. So we hope we can make this entertaining for you. We hope we can make it a little bit of fun. You did come to a medical marijuana seminar on April 20th. So if you're too easily offended, I apologize in advance, but we're going to have some fun with it. Along those lines, whatever I'm saying today, however learned it sounds, however impressive it is, and this goes for all of my co-panelists who you'll see are hiding, they're not even sitting with me at this point. We're not providing you legal advice. We're lawyers, we can provide you legal advice, but we're not providing you legal advice today. I don't think the doctor's providing any medical advice. So this is all just informational. So please don't take anything we say and go become a drug dealer. It's not a good idea. Typical airline hostess disclaimers. There's a bathroom. You go down the hall, it's to the left. There's munchies in the back. We got some brownies. We got maybe some Cheetos, whatever you enjoy. And there's more traditional, non-munchy breakfast foods right around the corner here behind the wall. Can everybody hear me okay? Yes. I said that louder, so I don't know how that's helpful. But what we're here today to talk about is medical marijuana in Pennsylvania. Specifically, how does it affect Pennsylvania employers and insurance carriers? I've got some news for you guys, though, because you're semi-famous. I'm sure you follow the Chartwell Law Offices on Twitter on a daily basis, and I'm sure you're aware that earlier this week, the Medical Marijuana in Arizona Daily Journal picked up on this presentation, and they tweeted about it. They tweeted out to their followers, and if you're clever in the ways of Twitter, you'll see that it got a like. It got one like. So if you weren't famous before, congratulations. We're here now. So I'll just leave that up there. You can enjoy. I need to start initially with position statements. So, even talking with people in the audience here, this could be a somewhat divisive topic. Some people are very supportive of medical marijuana. Some people are kind of, I don't know if this is going to work, but I don't really care. And some people are not very supportive. So what is our position, specifically me and perhaps Chartwell Law Offices, knowing that some of my partners are here and are worried about what I'm going to say right now. So let's talk about it.
These high school boys and girls are having a hop at the local soda fountain. Innocently they dance. Innocent of a new and deadly menace lurking behind closed doors. Marijuana, the burning weed with its roots in hell.
So that is our position. We are scared to death. This is bad news. Now, that was the wrong video. I apologize. Let me see
Is that a joint,
All right. That is not our position. That might be the other end of the spectrum. My point here is that we're not here to tell you what's right and what's wrong. We're here just to give you some information. It's a very interesting topic. A lot of people are really interested in how the program was set up, how is the program going, and perhaps not myself, but several of our hidden panelists are very educated in the area. They work in this area. They can tell you exactly what's going on in the industry much more so than I ever could. So with that, we should probably start with the legislative history. You know, where did medical marijuana come from? Where did marijuana come from in the United States? And I have what is my last dumb video to tell you how it works.
George Washington, man, he was in a cult. And the cult was in the aliens, man. You didn't know that? No. Oh, man, they were weighing that type of stuff. George took weed. Absolutely, George took weed. Are you kidding me, man? He even feels of that stuff, man. That's what I'm talking about. It feels. He grew that shit up, Mount Vernon, man. Mount Vernon, man. He grew it all over the country, man. He had people growing it all over the country, you know? The whole country back then was getting hot. Let me tell you, man, cause he knew. He was onto something, man. He knew that it would be a good cash crop for the southern states, man. So he grew fields of it, man. But you know what? Behind every good man, there's a woman. And that woman was Martha Washington, man. And every day George would come home, she'd have a big fat bowl waiting for him, man, when he'd come in the door, man. She was the hip lady, man. And she was real cool too. She'd harvest the crops, man. That's what I'm talking about. She'd put in the bushels and stuff and sell it, you know, because they had to, you know, make ends meet and stuff. I mean, did you ever look at a dollar bill, man? There's some spooky stuff going on a dollar bill, man. I mean, and it's green too.
Dumb video. There's a lot of truth in that video, right? I mean, every great man, there's a great woman. We got Martha Washington, cash crops. There is some relevance, though, and then the doctor and I were talking about this a little bit earlier. Since the Pennsylvania Medical Marijuana Act was passed 2 years ago, and since the dispensaries opened in February, there's been ongoing changes, and the Pennsylvania Medical Marijuana Board has been approving more and more stuff. Is that because they see it as a cash crop? I'm not going to be that suspect, but it's something that's really exploding in Pennsylvania and around the country. This is our question slide. A little bit different than the usual question slide. Typically when you see the question slide, it's the end of the presentation and you get up and you run out of the room because you want to go home. Thankfully nobody did that here. What we're doing with this is, and we've done it at a few other presentations, it can be either interesting and fun or a complete disaster. Because we have so much to go through, because we want to keep it moving, we want to take questions as much as possible, but sometimes the presentation gets bogged down. So if you have a question, please raise your hand and give us the question. If you don't want to interrupt the ongoing conversation, send me an email. I have my phone here, and the dual benefit of this is you can be on Twitter and on Facebook, and I'll think that you're emailing me because you're so engrossed in the presentation. But honestly, shoot me an email, give me the question. If it's not something we can get to today, I'll make sure the doctor or whoever our experts are follow up on it. That's the great thing about it, because we can take that email, send it to the expert that knows the answer, and get you the specific answer you're looking for. So this slide's going to come up throughout the presentation to talk about, you know, this is how we get questions forward now. All right, so a little bit beyond George and Martha Washington about medical marijuana in Pennsylvania. And I know the doctor and Barack are going to get into this more, and the second panel are going to get into this more. A very bird's eye, 50,000 foot viewpoint on the Pennsylvania Medical Marijuana Act, from my perspective, is basically that in April 2016, the legislature in Pennsylvania passed a law that allows certain people who have received certain approvals and are treating with certain doctors to gain access to certain forms of medical marijuana. And that's kind of the general setup. There's a lot more to it, obviously, that we're going to get into, but that's really the point. And as I was discussing with somebody earlier, I always look at the act and the regs as saying, these are the people that have access. It sets up the world of people that can have access to medical marijuana. It's not necessarily about saying who can't have it. It's about saying these are the people that qualify and this is how they can qualify. So this is the point where I give brief introductions of my panel. But I think I can remember them. I have my partner, Jacqueline Botero. Jacqueline's here.
Hello.
Rob Baker's also here. He's an employment law expert. Barack Casuto is going to be up next. I'll give more detail about him. We have Dr. Bruce Nicholson, who's an expert, and he's going to speak in a moment. We have Steve Auerbach. That was amazing. Steve's a timely guy. And then Adrian Breslin's going to be speaking with me as well. I hope I didn't miss anybody. Okay, good. Let me start with Barack. Barack Casuto is, let me give you your introduction. Barack's an attorney at Chartwell. He's been with us for a couple of years now. He's my go-to person. To the extent that anybody ever thinks I sound like I know what I'm talking about, it's probably because of Barack. He's fast becoming an expert in various specialized areas of Pennsylvania workers' compensation. He's already seized upon medical marijuana, not as a user, but as an educated person, and he's already informing our clients about how it works. He's a smart guy, he's well spoken. He went to Penn State, which is near and dear to my heart. So, Barack, why don't you come up here and introduce the doctor, and you can get going.
All right, thank you for Jason for that kind introduction and the disclaimer regarding usage. I will introduce our first panelist. Our first expert is Dr. Bruce Nicholson. Dr. Nicholson serves as the medical director for the Division of Pain Management for Lehigh Valley Hospital and Health Network. He was president of Pain Specialists of Greater Lehigh Valley in Allentown for over 20 years, until recently joining Lehigh Valley Physician Group. He's a founding member and current president of the Pennsylvania Pain Society and a clinical associate professor at the Penn State College of Medicine, Hershey. Dr. Nicholson is board certified in anesthesiology and pain management. He served in the Army Reserve Medical Corps for 9 years with an honorable discharge as mayor. He's also a major. He's also the chief medical officer for Standard Farms, which is one of the companies which was granted a license to grow medical marijuana in Pennsylvania. He's familiar with the issues surrounding medical marijuana, and he's our first expert. So let's welcome Dr. Nicholson. This, or do you want to sit?
Yes. So I guess this is sort of an informal discussion here, and I'm sure, as just not a pun, but there are a lot of burning questions about cannabis, and I appreciate Jason's introduction in regards to cannabis, and I'll give you a little bit of my background. As Barack has already said, I've been in the field of medicine for a number of years, and over that period of time, I've been involved with a lot of clinical trials, a lot of straightforward, what I would call traditional medicine approaches, and so this was a little bit of a deviation for me. I've never had a ponytail, so I really don't qualify as a classic stoner or someone who you would normally picture as an individual. When I go back to high school, I played high school hockey and college hockey, and I look like one of the guys from Slapshot back then, but that's the closest I ever got to it. But other than that, I've been in the field of pain medicine for about 25 years and have really had the opportunity to see a growth in how we manage patients. And it was actually that experience in my time doing this and doing clinical research that really sort of piqued my interest from the perspective of potential benefits of medical cannabis. And I use the term specifically medical cannabis as opposed to marijuana. I helped formulate some of the different aspects of the state regulations, working with Dalen Leach and Mike Fulmer. And one of the things, unfortunately, we were not able to change was what I would call a pejorative term of marijuana. If you go back historically, marijuana really was specifically a term that was used. And if you go to, has anybody seen Reefer Madness? Ah, what a great movie. But anyways, it really was a term that was sort of brought to the forefront in the 30s and 40s. And if anybody knows the history, does anybody know the history of why cannabis became an illegal substance in the United States? It actually really was an itis that occurred in Pennsylvania. The whole idea, Pennsylvania and California. There were three individuals, particularly the DuPonts, the Mellons, and the Hearsts, who, because of concerns about potential challenges to some of the different evolving technologies, particularly in paper and in fibers, were concerned about one of the cash crops. And actually, this last video, when they talk about the cash crop of Mount Vernon, one of the most important cash crops up until the 20th century in the United States was hemp. If you go over the couple blocks from here, you'll see one of the original documents in the United States that's actually written on hemp, and that's our Constitution. The original flag that was sewn and put together by Betsy Ross was on hemp as well. Hemp has tremendous capabilities, and that's really why Jefferson has gotten involved with hemp, not as much for CBD, but for the fibers and the opportunities within that field of where they can go with it. But hemp posed a threat to some advances, and if you look at the paper industry and you look at what happened in the 30s with DuPont developing nylon, hemp was still one of the most important crops out there. And so there was a concern about how they could actually compete with hemp because it was grown by most farmers. It was cheap. As a matter of fact, most states, and Pennsylvania was one of the states that had a mandate that they had to grow a certain amount of hemp. So in order to deal with that aspect of what was going on with ongoing growing of hemp, these guys got together and they colluded, and they couldn't figure out how to get rid of hemp. So they said, well, what's the big brother and what is the other crop that's very closely aligned with hemp? It's actually in the same family, genus, and that is cannabis, i.e. marijuana. So in order to actually affect any restrictions on hemp, they first went for cannabis. And in 1937, the American Medical Society actually had a position and wrote a position and had a position that was very pro cannabis, based on the fact that at that time there were over 100 indications for the use of THC, CBD compounds. But in spite of that overwhelming political and money, trumped, no pun intended, trumped the value of cannabis as far as for its medical use, and it was outlawed. Very quickly after that, when they outlawed cannabis, they said, how can law officers tell the difference between marijuana and hemp? Well, the only difference is one has 5 leaves, one has 9 leaves, and the other has 7 leaves. So they said, these guys might not be able to count those, so we better also put hemp in the same category as marijuana so that our law officers don't have difficulty discerning the difference between the two of them. So both of them were outlawed in 1937 with the Marijuana Tax Act, or shortly after that. And then things just started to move forward as far as more and more quote unquote scientific data that supported the fact that marijuana was a dangerous drug. However, if we look at this, stop me anytime if I
So first of all, happy ending for hemp. You can buy it at Trader Joe's now, so very healthy.
Absolutely, it's got better composition of omega compounds than anything else out there.
But that's not the subject of today's presentation. So let's talk about cannabis. What is it? How does it work?
Well, moving fast forwarding, if we look at the whole history, other than how it got to where it is now as a DEA Schedule I substance, the majority of the research started to evolve out of Israel. There's a gentleman, a PhD guy in 1968 or 69, Raphael Meshulam, that became interested, and he was at, I think it was Hebrew University, and was able to get a crop, or I should say a seizure of very high quality cannabis that the individuals had seized that was coming into the country, and he started to do some research on it, and he realized that this had some interesting characteristics to it. So he was able to actually identify a couple of different substances, first being the THC compound and then the CBDs. The THC is an isolated compound that has psychoactive effects. So anybody who utilizes cannabis has, and depending on the balance and the ratios of the CBD to THC, may have some effect from a psychoactive component. And that's usually, if you look at the literature and you look at all the propaganda, that's what they illustrate, is people smoking it and getting crazy and all these types of things, as opposed to Cheech and Chong, where they just sort of slow down and actually do almost nothing. And I've got some friends that actually are policemen, and they say it's sort of interesting when, and they work up in the Lehigh Valley, and they have to quite often go break up fraternity and sorority parties. They say when they get a call or with a group of individuals, somebody calls and says, hey, I think there's some marijuana being smoked. They say they send one police car out with one guy. The guy goes, knocks on the door, and opens the door, and everyone goes, hey, what's going on? And that's the end of it. They say, when you get, because everybody is sort of docile, they're just very low-keyed, as opposed to when they go and these guys have to go into a party that's alcohol. They have to send one squad car with 2 guys and 2 backups. So it's a very different type of interaction with the nervous system. When I say interaction with the nervous system, THC interacts directly with the brain, and it actually acts directly on what are called CB1, cannabinoid receptor 1. And by doing that, what it does is it affects a downstream release of different neurochemicals. You have the second, which Raphael Mechoulam identified several years later, was what is called the CB2 receptor. The CB2 receptor is a receptor that is present peripherally and has significant anti-inflammatory effects and a number of other downstream effects that really are very interesting. Cannabinoids are 20 times more potent than aspirin as an anti-inflammatory. They also have been shown to have neuroprotective effects. The federal government in 2002 patented the neuroprotective effects related to cannabinoids. Tremendous amount of work has been done over a number of years by the federal government in attempts to try to put marijuana again and cannabis in a position where it's been shown to actually have a negative effect. The majority of the work that has come out of NIH and NIDA has actually had the opposite effect. They've shown tremendous therapeutic values. The problem with it is, when we look at it, I've mentioned THC and I've mentioned CBDs. When you look at the plant produces a wide spectrum of different substances. THC comes in 2 forms. It's THCA and THC that's been cleaved in the active form.
Doctor, I'm just going to interrupt you for a second. So the THC and the CBD, are those the 2 primary pharmacological compounds that are used in cannabis?
Yes, those are the 2 pharmacologic compounds. The CBD, the cannabinoids, though, run a spectrum of anywhere from 90 to over 200 different substances that fall under the category of CBDs. And that's why, from a pharmacologic standpoint, the federal government is having a difficult time not approving its use from a medical standpoint, but understanding how to classify it when you do studies. And I've been involved in, as I mentioned, studies for over 25 years and worked in this field and done a lot of clinical development with pharmaceutical companies. And the challenge that you have here is classifying a substance that you don't know whether it's the primary component in CBDs when you grow it, and I've got a picture of our facility and in some of the different plants there. When you grow it, you actually grow a plant that has a wide spectrum of a number of CBDs. The state has a requirement for each one of the grow facilities to identify the amount of THC that is present in each one of their batches that are produced, and also at least 9 of the more prominent different CBD components that are there.
So we'll get into the grow facility in a moment. So the THC is the psychoactive compound, right?
This THC is the primary psychoactive compound. When I say the primary one, if you actually look at the data for CBDs, or the cannabinoids that affect the CB2 receptor, they have very potent anxiolytic effects. They work very similar from the standpoint of calming individuals down as you would see with a benzodiazepine. So it does have a psychoactive effect, but it doesn't have a excitatory or that, I'm not sure what term to use from the psychiatry literature, but it doesn't have that same high effect that THC has.
And for the folks in the audience who are not familiar, this is different from, let's say, an LSD psychoactive effect, right?
Absolutely, absolutely. The LSD, and I don't know whether some of you are familiar with some of the literature that's now evolving that talks about microdosing of LSD. They act at completely different receptors. LSD acts at the same receptors as methamphetamine, so it's a very excitatory response, and the THC acts again at a very different receptor complex.
Does it cause visual hallucinations?
It's thought that in some of the development of very, very high concentrated amounts of THC, you may actually experience some hallucinations. But we're talking concentrations of 30%, 40 and 50% by volume THC specific compounds. So the medical compounds that are available, 2, 4, 6, 10% by volume THC should not cause any hallucinatory effects.
Okay. So can you tell our guests a little bit about your work with Standard Farms?
My work with Standard Farms goes back to shortly after they received a license. Actually, as I mentioned, I was involved with developing some of the medical guidelines for the bill that was passed in 2006, April of 2006, and actually was involved with an application. Didn't receive the application as far as a grant to grow process in the state. So very shortly after that, I received a call from the people at Standard Farms, and they said, we really need somebody that can help us understand what we're doing from the standpoint of meeting a medical need. So I met with them, and for the last 2 years, I've been working with Standard Farms, helping them understand how to balance their components of their extracts. And when I say extracts, as you've read, if you read the state regulations, everything comes in an extract form. Now, this past Monday, Rachel Levine, the head of the Department of Health, indicated that going forward there would be an opportunity to use dry leaf in a combustible form in a vapor. But up until that point in time, everything that you will find in a dispensary is in an extracted form. So my role with Standard Farms was to help them put together formulations through an extraction process and help them understand what the balances of THC and CBD needed to be when it went out to the dispensaries in order to optimize responses that patients would have when they utilized the product.
And Standard Farms, I'm going to try to operate the slideshow here. Standard Farms was one of the, is it 2 or 3 companies in Pennsylvania that got a grow license?
12.
12 companies. But how many are active right now?
2.
2 companies. So
we were able to, Cresco Labs that our Cresco Labs is out in the Pittsburgh area, was the first company to actually produce a product that was able to be delivered to the dispensaries. About 4 weeks later, Standard Farms produced their product. At this point in time, we still only have the 2 grow facilities that cannot even come close to meeting the demand in the state. There are over 25,000 individuals in the state of Pennsylvania currently that have applications in place to go through the process of receiving a card so that they can obtain medical cannabis. There have been over 11,000 individuals that have accessed the few dispensaries. So when you look at that, and this is what our grow facility looks like. It's indoors, it's a secured grow facility. We don't have armed guards up there, but it is a very secured facility that allows us to grow at different stages of growth, full spectrum cannabis. And when I say full spectrum, it varies depending on the strain, how much THC you have, and how much CBD, and what the complex of the composition of the cannabinoids are in this. So this is one of our pictures of an almost mature crop. And when you look at this, what you see on the top are the stalks with a lot of what's called bud in flower. This is just before the flowering stage. And there are what are called trichomes on the top of here. And the trichomes actually are where the majority of the THC and the CBD is sequestered. So we take these plants, we cut these down when they're fully mature at about 2 to 2.5 feet, and then they're put through an extraction process through what's called supercritical CO2 extraction, where you take CO2 and you push it to about 3,000 to 5,000 psi. When you push it to 3,000 to 5,000 psi, it actually becomes a liquid, and you emulsify the plant. And by emulsifying it, then you can actually take off decant off the THC, CBDs, and what are called the terpenes. I'm not going to ask anybody whether they have any experience in cannabis, because I don't want to incriminate anybody in the audience here. But if you've ever smelled that pungent smell of cannabis, that's what's called, that's the terpene component. The terpenes actually are thought to play a role. So what we do is we extract off all 3 of these, and then you put them back into a combination in a formulation that can be distributed then to the dispensaries.
So we talked a little bit about what cannabis is, how it works, where it comes from. Let's say a physician in Pennsylvania wants to prescribe cannabis or refer a patient for medical cannabis. How does that work?
Okay, in Pennsylvania, the way the regulations are set up, very similar to most states. We can't prescribe, we can only recommend. And the reason why is because it's still considered a Schedule I substance on a federal level. As a physician, I receive my privilege to prescribe from the federal government. I get also something from the state that says I'm qualified to prescribe scheduled substances, but my right to prescribe a scheduled substance comes from the federal government, and that gives me my DEA card that says, and my certificate that tells me that I can prescribe Schedule II, Schedule III, Schedule IV, and Schedule V substances. What it also states is there is no such thing as a prescription for a Schedule I, which is LSD, heroin, other types of drugs that have been put on that, in that category. So in Pennsylvania, what you do is you, as a clinician, you take a 4-hour course. 4 hours is the minimum amount that I would feel that would even give you, let you scratch the surface. I've been involved in this, as I mentioned, this space for 4 years now. I probably spend at least 2 to 4 hours a week reading on this. And even with that, I feel like I'm not really fully abreast of understanding this. So the 4 hours allows you to one, as a clinician, understand what the state regulations are. State regulations including the conditions that are available to make those recommendations. And recommendations are what we do. We make a recommendation based on the patient's history. Whether they have chronic pain, which usually constitutes about 80% of all the recommendations for cannabis, are related to chronic pain. The other 20% fall across the spectrum, from seizure disorder to Parkinson's to ALS, and now in a short order, we're also going to be able to make recommendations for medical cannabis for the treatment of opioid dependency and addiction. It's going to be a huge step forward in the fight related to opioid issues in the state of Pennsylvania, where, as you guys probably know, we rank number 5 in the nation as far as deaths. But so you take the course, and then you actually then certify with the state. You fill out a form that identifies who you are, where your locations are, and then at that point in time, you're actually certified to now be able to make recommendations to patients. What's interesting is all patients that you make recommendations for, if they're not in your practice or you're doing it specifically for the recommendation of medical cannabis as a payment model.
So let's say a physician refers a patient for medical cannabis. Do they then have to report that interaction with the patient anywhere?
The only report that is required is in your medical records specifically. You don't have, what you do also is when the patient comes in, they will have already accessed online, and everything is done online. They will have registered with the state. The state then vets them to ensure that they're not a drug dealer. I don't know why a drug dealer would want to do this anyways, because it's much more expensive than what you can get on the street. But that being said, they want to vet you to make sure that you're not a felon or anything of that nature. And then once you do that, then you come in, you're examined by the physician. The recommendation can be made. The physician goes online, fills out a short form to then certify you as a patient who is eligible for medical cannabis. That goes back to the state. The individual pays $50 and then receives a card. And if you're indigent, you can get an exception and not have to pay anything. But you pay $50 and then you can receive your card.
Now, one of the things that I found interesting about this program is that it's a little bit different from a typical prescription setup. In a typical prescription setup, as I'm sure most of you are familiar, the physician writes the drug, the dosage, how often you're supposed to take it. It's a little bit different with medical cannabis. Can you tell us how that works, doctor?
Yes, it's a little unsettling, to say the least, in the medical community. And even though we've had some significant movement forward, there are over 500 physicians now in the state of Pennsylvania who are certified, there's pushback by clinicians, and part of the pushback has to do with what Barack has just alluded to, the fact that when we write a prescription for any drug, we know exactly what the patient's getting. They go to the pharmacy, they may get a generic or they may get a branded drug, but we pretty much know if I write for oxycodone 15 milligrams, they're going to go to the pharmacy and they're going to get oxycodone 15 milligrams. They're not going to get morphine 15 or some other drug. So I know exactly what they're getting. The problem with the current environment with medical cannabis is if I make a recommendation for somebody and I'm not specific, and actually the regulations do articulate that as a clinician, if I want to, I can specifically state what I want my patient to receive. But the vast majority of physicians, because this is only a 4-hour course, will defer to the dispensary to make that decision outside of any direction of the clinician as to what the patient will receive when they get to the dispensary. That's a model that is very foreign to anyone in the medical profession.
So it's ultimately the patient and the individuals at the dispensary who determine the dose, the the particular strain or the combination of CBD and THC?
Yes, it will be the individual at the dispensary, and every patient is mandated to be at least evaluated by a pharmacist. The pharmacist will take a history in regards to the patient, and then the patient goes back, and depending on which, I've had some interesting feedback already from patients, who they actually meet with. And I'll leave the dispensaries unnamed. Some of them are very professional, and some of them are anything but professional, and they should probably be out in Nevada or California, where they are bud tenders, not professionals. I've had a couple of patients come back to me and say, I felt like I was in a pretty sleazy environment. And I said, well, what do you mean by that? They said, well, I had this interview with the pharmacist, and then I went back in this little room, and some guy sat me across the table from me, and he had gauges in his ears, and he was all tattooed up. And he said, now, how high do you want to get? And what's your real reason for getting this? And this was a lady who'd had a couple back surgeries. She had arachnoiditis. She had clear-cut neuropathic symptoms, didn't really tolerate other medications well. So her idea was, well, you know, she'd done a lot of reading. This is a lady who had a master's in social work. So she was very well educated. And she said, I was pretty offended by this, that this guy, and he insisted that I must have a history of use of marijuana. And she goes, I'm a mother of 4 kids. I'm a responsible individual. And I told him, I have never touched this stuff. And she was completely turned off, as opposed to, I had a 75-year-old lady yesterday come in. She is utilizing it, and she went to the different dispensary, sat down with the pharmacist talked to her. She goes back and she sits down with a technician, not a bud tender, which this guy called himself a bud tender, with a technician, and actually came out with a formulation that has been quite effective in managing her symptoms. So that's really the interaction that you get, and it can be quite variable.
I think we have a slide of the different products that are available at the dispensaries currently. Here's another photo of the grow operation, and here we go. So medical marijuana or medical cannabis in Pennsylvania is only available in certain forms at the moment. Doctor, can you tell us about those?
Yeah, the forms right now, as I alluded to before, are all in extracted forms. That will change very shortly, but the extracted forms allow the grow facilities to actually balance different amounts of THC to CBD outside of the strain. Strains will become more important now that there will be vaporization by leaf. And the reason why I say that is strains really constitute different genetic combinations that will vary the amount of THC, CBD, and the terpenes specific to that leaf that someone is actually using in a vapor form. This, however, as you can see, are vape cartridges, and you're all familiar with the e-cigarettes. It's the same concept. Vape is actually a liquid, a concentrated liquid of either THC, CBD, or balance along with terpenes. And when you vape, basically what you do is you heat it up, and you don't combust it. You actually turn it into a vapor formulation. So it doesn't burn this, it actually just heats it. And then you inhale it. And it's the most rapid way to actually affect a response. And I say rapid way because you take it and you put it into your lungs, and the size of the surface of the lungs allows it to be absorbed, and you get what's called first pass response. In other words, it passes by the liver, it goes right to the brain, goes right to the central nervous system. So you get not only a more robust response as far as the THC, but you get a more robust response as far as the cannabinoids and the other aspects. The second are the capsules. The capsules are probably more popular, that and the third, the Tincher, than any of the others. reason why I say they're more popular is because right now we're seeing a large number of older patients, and the older, when I say older, that's all relative, I guess, to your age. But when I talk about, I'm talking about 75-year-olds who say, I really don't want to sit there with a vape pen and suck this stuff down into my lungs. What I want is something that's very similar to what I'm used to. And when I say what I'm used to, we're a pill-taking society. We take more pills than any other country in the world. So people really want something that they can ingest orally. The problem with the ingestion orally and putting it into your GI tract is you have what's called first pass through the liver. So you have to use a higher amount of THC, a higher amount of CBD. You have a much more delayed response. The vape pen actually allows response within about 3 to 5 minutes. The capsule, it takes at least an hour to see effect, but it lasts a lot longer. The vape pen response will last about 2 to 3 hours if anybody's experienced responses of cannabis before. So it wears off in about 2 to 3 hours. The capsule stays around for about 68 hours.
What is the tincture, doctor?
The tincture is the third form, and the oil is very similar to this from the standpoint of what you use is a very concentrated form, and it goes under the tongue. The tongue has is a very the sublingual area is very vascularized, and so and cannabis by general is lipophilic. In other words, it's absorbed pretty easily through the membranes. So you put a very concentrated form of this under the tongue. It's absorbed. Onset of action is about 15 minutes. Duration is about 4 to 5 hours. This is actually one of the most popular form right now because this is what's available for most of the older patients. Capsules still really is, we're still developing. We're starting to produce capsules at this point, but haven't gotten enough of them out. But the tincture has a relatively rapid onset. It passes by the liver again, so you can use lower concentrations and get good results. The average cost for this, anybody want to take a guess for a month? How much? We're talking $300–400. Actually, I had a lady come in yesterday. She uses it twice a day. My 75-year-old uses this 2 to 3 times a day. $70 for a whole month. Co-pays for our drugs nowadays are even more than that. So I told her, I said, man, I said, I should really get into this business. I was just kidding with her because I'm the medical director. But you know, $70 is a very reasonable amount for a whole month.
So something I think a lot of our guests might be interested in is if a patient is taking medical cannabis, what, if any, is their level of impairment, or does that depend?
It really depends. And the analogy I use is if you're naive, and again, most of my 70-year-olds, they're naive when it comes to this stuff. They remember back to college, but outside of that, they haven't used this substance for years. And what I tell them is it's very similar to, and by the way, I don't have any personal experience with this. From people that have told me, it's similar to actually having 1 or 2 glasses of wine on an empty stomach. So you may get a little bit of a buzz, and patients will tell you that, but actually, if you look at the literature on cannabis, it's from the standpoint of risk, probably lower risk of injury to an individual than opioids. And if we look at the states, in Colorado and California, that data actually supports it. That concept is actually supported because they've seen, other than certain times of year like 420, actually, there are lower incidences of motor vehicle accidents in those states that have opened up cannabis at a more liberal level than other states. And actually, it's an interesting product. As you all know, when you talk about alcohol, some people say, I can drink a lot because I drink every day. No, you don't upregulate your liver any significant amount as far as being able to break down alcohol. You are limited to how rapidly you can break alcohol down. So these people who say, yeah, I can drink 7 drinks and still drive. Now, they're still impaired. Even though they can drink 7 drinks every day, they're still impaired. The interesting thing about cannabis is the longer you use it, the less effect as far as the psychoactive component occurs with the THC. You actually upregulate what is called the P450 pathway subenzyme system to actually break that THC down more rapidly. So people actually habituate to the psychoactive component. And so over time, and this is where one of the issues from a legal standpoint comes up. If you have somebody that is just starting to use it, their impairment level may be much higher than someone who's been using it consistently over a period of time from a psychoactive component.
And I'll touch on another legal point. I think the doctor mentioned it briefly, but if you've been reading the news about medical cannabis, the Medical Cannabis Advisory Board recently published its recommendations to amend the regulations regarding medical cannabis. And the Secretary of Health in Pennsylvania has stated that they intend to approve those recommendations, and they will be incorporated via amendment into the regulations. The anticipation is in May sometime in the Pennsylvania Bulletin. So one of those changes is that there's going to be a new form of medical cannabis available. It's going to be vaporization of whole leaf. Doctor, can you tell us, does that change the medical aspect of this at all?
I think it does, and the reason why I say I think it does is because, again, as physicians, as I've already alluded to, this is a very foreign model for us to understand how to make a recommendation and then feel comfortable with what happens once that person leaves your office and the black box is there and you have no idea what they're getting. We, as clinicians, we grew up in an environment telling everybody, don't smoke, don't smoke. And this was part of really my agenda when I worked with Dalen and Mike Fulmer. These guys, I told them, I said, if you want this to be accepted in the medical community, don't put smoking out there. And to this day, actually, I'm glad that it really has not come out like that, but this, I think, may be an impediment moving forward for more clinicians to get involved, and it may be good and may be bad. Physicians may take a more active role and say, I don't want my patients smoking leaf. I want them to use the extracted form, even though if you look at the literature, and there have been retrospective reviews and prospective studies that have followed individuals over years. And it shows that actually it's interesting that cannabis by itself, when inhaled, has virtually no pathologic effect on the lung, the lining of the lung, like with tar and nicotine from cigarettes. Over a period of time, it breaks down the epithelium. That's what leads to COPD. And it's actually thought that the CB1 or CB2 receptors in the lung actually have a protective effect. So you take people over 20 years who have smoked cannabis, their lung function is almost no different than parallel groups that have never touched a cigarette, never touched cannabis.
And one of the other new regulations that's anticipated is an expansion of the accepted conditions for use of medical cannabis. And one of those is treatment for opioid addiction. What does it look like once the new regulation is passed, taking a patient from opiates to medical cannabis?
It's interesting. If we look at the literature, over the last 3 to 4 years, there have been several retrospective reviews published looking at states that have passed medical cannabis laws or regulations, as well as states that now have currently available recreational use. And what we've seen in these particular states is, overall, decrease in the number of individuals using opioids, and some of my colleagues, particularly one in particular, Mark Wallace from UC San Diego, has been extensively involved in this area for 20 years, has been able to demonstrate that patients who come in and that are on opioids, he's able to, in over 50% of those patients, titrate them off of opioids completely. I would suggest that anybody who wants to see an interesting, what I would call disruptive concept in the whole area of opioid addiction, go online, look at the video High Sobriety. Joe Schrank out of LA. He did a piece on NBC about 6-8 months ago. But Joe's developed this program, and it's sort of interesting, he calls it High Sobriety, where he takes individuals who have failed traditional rehab, and Joe's been in the rehab space for over 30 years. They've failed traditional rehab, and he brings them in. They may be on Suboxone, they may be on methadone, but they clearly want to go back, and they've had at least 1 or 2 or even 3 or 4 incidences where they've gone back to heroin or using substances illegally. He brings them in, he puts them on a defined amount of cannabis, and his success rate far surpasses anything you see in the rehab industry. I find it sort of interesting. They talk about what's the definition of insanity? Doing the same thing over and over again and expecting a different outcome. You guys know what the success rate is. I mean, in workman's comp, you know what the success rate is if you send somebody through a rehab facility. As far as the likelihood of them getting better, 10%. So they keep using the same model. 90% of people are going to go back and do the same thing. So you have to say, well, are there other models potentially out there? Well, it runs counter to what you would expect people to say, well, God, this person's not sober. Well, is it as much about being sober as it is about being alive and functional? And what Joe in High Sobriety has been able to do is keep people alive, keep them functional, actually by substituting medical cannabis and utilizing that, whether you want to call it a crutch or whatever, to actually allow these people to transition back. So the data is starting to evolve that it is safe, and there certainly are a lot of questions, without question.
So we have a list of the accepted conditions. That's the 17 conditions that are already accepted by the Act are in the handout in front of everyone. And there's some more coming in the pipeline via regulation, which we anticipate. Those are also in there. But besides the specific diagnoses, what are you looking for when you make a referral for medical cannabis in a patient? Are there any contraindications?
Yes, what we look for is patients, one, they truly, and the state statute and the legislation specifically articulates that this should not be a first-line treatment. If a patient comes in, they haven't been tried on traditional therapy, we're going to, for the most part, trial them on traditional therapy. Whether we're talking about somebody with a failed back, we're talking about somebody with a diagnosis of fibromyalgia, or what have you, we're going to put them through a traditional therapy program, traditional medical program. If they fail, and they can fail on multiple levels, they can fail because they have tried it before and it didn't work. They can fail because they have side effects or they just can't follow through with it. So we're going to put them through the traditional model. When they fail the traditional model, then we say, okay, is this person really a candidate for medical cannabis? And some of it that has to do with the psychological makeup. There's probably a couple of what I would call relative contraindications to the use of cannabis. That is individuals that have significant psychiatric comorbidities, particularly what we know from the standpoint of paranoid delusional behavior, schizophrenia, significant levels of anxiety. And when I say anxiety, individuals that may have PTSD with high levels of anxiety, even though it is approved for PTSD, You have to be careful, particularly in the combinations. CBD has been shown to be beneficial with people with high levels of anxiety. The problem is when you throw THC in there, the psychoactive component, it can do the exact opposite for patients. And I had that experience with one of my patients 2 weeks ago. There's a gentleman, 69 years old, had 4 or 5 back surgeries, had a fusion of his ankle, had both knees replaced, didn't tolerate opioids well. This guy was a Vietnam vet, spent 7 tours in Vietnam as a sniper. So needless to say, this guy probably had a lot going on up here. He's treated by the VA, has been on pretty heavy doses of benzodiazepines and other drugs for PTSD and anxiety. He wanted to try medical cannabis based on the fact that opioids, he just didn't do well with them. So he goes to the dispensary and he gets his history to him. Well, and I spoke to this earlier before we had the conference. The guy said, well, you know, we're somewhat out of a lot of the different formulations, but how about if I give you this formulation, the Tincher? So he gives him a formulation of the Tincher. Guy says he goes home, he uses the 2 drops like he's supposed to, and he said, it was the worst experience I've had since Vietnam. And I said, what do you mean by that? He goes, I couldn't figure out where I was. I had to call my wife, and I ended up 2 blocks down in the bushes, hiding in the bushes, because I couldn't deal with the results of using this. And his wife took him to the emergency department. Emergency department did the exact opposite of what they should have. They said, well, you better not take your Xanax for the next day. Well, that actually amplified his responses to it. But this guy should have never received a high THC formulation. He received a formulation that had almost no CBD, all THC. So he actually, as Barack mentioned, I don't think he was hallucinating, but he had some pretty bad flashbacks, I'm sure, with this.
And that's one of the things that they do at the dispensary is it's the form, the dosage, but also the percentage of THC versus CBD.
Yes.
That's determined by the dispensary. We're starting to get towards the end of our time here, Doctor. Do you have any anecdotes of positive patient outcomes?
Oh, yes.
Okay.
Yeah. Yeah, the lady that I mentioned earlier, the 75-year-old who I saw 2 days ago who came in, has done wonderful. This is a lady who, she has terrible spine problems. She's had a couple back surgeries. She can barely stand up straight, has tried opioids, and really didn't do well with opioids. And so she was certified. She came back in yesterday. She said, this has been remarkable. She gave me a pain score of 1 on a scale of 0 to 10. Prior to that, every time she came in, it was a pain score of, I could guess, 9 or 10, maybe 8 if on a good day for her. And she said, this has been remarkable. She goes, I have really had tremendous results with this. I'm not taking, she was on low-dose Nucynta because she didn't tolerate opioids well. If you're familiar with this, it's one that has a low side effect profile. She said, I don't have to take anything else. And her husband was elated by the fact that she was doing much better. She could go out, she could participate in social activities. So yes, and I've got numerous examples, anecdotes of individuals who do well, but I also have them, and it's like any therapy we provide patients. There are positives and there are negatives. There's no absolute, and that's what I tell patients right up front. They all come in, they say, oh, I want to try this. I know it's going to be the end all, the be all. It's going to work for me. I say, no, it's like everything else. We'll trial you on it. You may or may not have benefit, but clearly it's got an opportunity to improve your quality of life when it works.
I think that's a good stopping point. So we're going to take a break now. Everyone can get some more coffee, stretch their